invitation. I thank Dr. Amalia Bishlawi for allowing me this presentation, and I thank Amgen. We are now going to discuss relapsed refractory multiple myeloma and the use of second-generation proteasome inhibitors, and maybe beyond. My name is Dr. Mervat Mattar, and you know, how to attack a myeloma cell? Well, there are different ways. Of course, in the past there used to be the regular combination chemotherapy, but then came other medications such as the immunomodulators that mainly affect the microenvironment around the myeloma cell. There are also the proteasome inhibitors, mainly first generation Velcade, which affect the they decrease against the proteasome, and so they accumulate waste products inside the cell, and so the cell is apoptosed. There are other ways of treatment, such as the monoclonal antibodies that attack the CD38 on the myeloma cell or others, and of course the anti-PD-1, PD-L1 inhibitors, and these act by accelerating apoptosis of the cell. And of course there are the CAR T-cell therapies that make the patient's immune system attack the myeloma cell, and at the end we are aiming at apoptosis of the myeloma cell. Let us first concentrate on Velcade. Now Velcade, the proteasome, this is the first generation proteasome inhibitor, and it worked very well in the frontline setting. However, with relapsed refractory myeloma treatment, there is another problem, and they have been advising that if you use a Velcade-based regimen and then the patient relapses, then you can use a lenalidomide-based regimen, and vice versa. However, these days, probably you are using both first line, and at this point, if you are using them again in second line as salvage, if refractory cases happen, or after relapse, then probably this is not going to work, and you will be needing to change one or both, or add another element to either of them, or else the responses will not be that well. And as you can see, using bortezomib-based regimens in the relapsed refractory setting gives, as you see in green here, less median progression-free survival than others. I mean, here we are comparing Velcade Dex, which is usually used as frontline, to other medications, whether the addition of daratumumab, monoclonal antibody, or versus the use of second-generation proteasome inhibitor, Kyprolis or carfilzomib, or the use of others. And as you can see here, Velcade Dexa in the relapsed refractory setting is not working well, whether regarding median progression-free survival or even in the overall survival estimation. And so there was an unmet need for relapsed refractory multiple myeloma, and here stepped in the second generation proteasome inhibitor, carfilzomib, which is a selective proteasome inhibitor that is irreversibly and specifically binds to the active sites of the proteasome, and this way it can act maybe stronger and can make use of, can be of use in cases of myeloma that are now relapsing or that are refractory to bortezomib. And in relapsed refractory cases, carfilzomib has been used in combination with dexamethasone or in combination with pomalidomide, which is the third generation IMiD or immunomodulator, or in combination with the monoclonal antibody daratumumab. And as you can see, it gave very good overall response rates, up to 84%, and it gave very good median progression-free survival in months, reaching up to 25.7 months, or a very good overall median overall survival, which has not, the median of which has not been reached in many studies. And so it gave better results if used in the relapsed refractory setting. Let us look at another type of proteasome inhibitor, which is the third generation ixazomib. This is oral. And the tourmaline study, the combination of ixazomib with Revlimid and Dexa gave overall responses of 78%, which is comparable to what carfilzomib is given, and a median progression-free survival of 20.6 months. So, regarding carfilzomib, why is it of benefit? It is of benefit because of the studies that have used carfilzomib and that have proven efficacy in the relapsed refractory setting. And look at the ASPIRE study, which included 792 patients. This is a considerable number of patients. And these were stratified by beta-2 microglobulin levels, by if the patient has had bortezomib before or lenalidomide before. Why? Because here carfilzomib is given instead of bortezomib in combination with Revlimid, which is lenalidomide, again, together with DEXA. And here carfilzomib is given in the dose of 27 milligram per meter squared IV over 10 minutes on days 1, 2, 8 and 9, 15 and 16 milligram per meter squared doses, together with lenalidomide in the 25 milligram dose and dexamethasone in the 40 milligram dose. And these were compared to the use of lenalidomide dexa without a proteasome inhibitor at all, so without kyprolis. However, there is a caveat here because this study stopped carfilzomib after cycle 18. Patients that were on this arm just received carfilzomib for 18 cycles. Now, response rates were better with the addition of kyprolis in comparison with RD without kyprolis, both in early and late relapse patients. And this is very good because, especially in early relapses, that means that the patient probably is going to be a bad responsive patient. However, as you can see, the overall response was 83.2 patients with the addition of carfilzomib. And look at the red. The red is a PR plus very good partial remission, while there were 22.1% with complete remission. And also in 8 relapses, we had an overall response rate of 89% of cases, and of course more CRs and very good partial remissions in comparison to Revlimid dexa alone. Now, how about the median progression-free survival? Still, the median progression-free survival in blue, with the addition of kyprolis, gave better results. So the combination, the triple combination of KRD, gave a better response than the doublet RD alone. And the median progression-free survival was 26.1 versus 16.6 months. And so a better median overall survival also by 7.9 months. So not only the median progression-free survival was prolonged, but also the overall survival was prolonged by 7.9 months in blue with the addition of kyprolis versus yellow without kyprolis. And so the ASPIRE concluded that by subgroup analysis, progression-free survival was better with the addition of kyprolis versus non-kyprolis, whether the patient had had 1 prior line of therapy or 2 prior lines of therapy, and whether the patient had had a previous Velcade or not. As you can see here, the progression-free survival is always better in red with the kyprolis arm versus the RD arm. Regarding overall survival, whether the patient had had 1 prior line of therapy or not, whether he had been exposed to another proteasome inhibitor, bortezomib, or not, whether he had been transplanted before or not, any way, in relapse, the addition of kyprolis gave better median overall survival versus RD alone. So always a triplet is better than a doublet, and a triplet with a second-generation proteasome inhibitor in the relapsed refractory setting is better than a doublet with Revlimid dexa alone. So this was comparing the addition of carfilzomib to RD or the non-addition of carfilzomib with RD. How about the ENDEAVOR trial? ENDEAVOR trial here is comparing a head-to-head trial. It is a head-to-head trial comparing first-generation Velcade dexa to second-generation kyprolis dexa in the relapsed refractory setting. And these were a considerable number of patients, 129 patients. And they were stratified according to prior proteasome inhibitor therapy, which probably was Velcade before, or others, Prior lines of treatment, 1, 2, 3 prior lines of treatment, the ISS stage, and the route of IV administration, because some of the patients received Velcade subcutaneously. And here they were more courageous. The carfilzomib was not the 27 milligram per meter square dose, but it was the 56 milligram per meter per square dose, and it was given intravenously, probably around 30 minutes, rather than over 10 minutes only, which was in the lower dose. And this was compared to Velcade Dexa in the regular dose with the addition of dexamethasone in both arms. Here, carfilzomib was continued indefinitely. It was continued until lack of response or until an adverse event. It was not stopped after 18 cycles as the ASPIRE study. And as you can see here, carfilzomib led to high response rates both in early and in late relapse patients. And as you can see here, the overall response rate in early relapse, which is the most serious, is 63.4%. And also in late relapse, it was even better, 81.8 relapse overall response rates. And that was compared to Velcade, which was only 49.1 in early relapses and 66.8 in late relapses. How about the progression-free survival? Well, KD, Kyprolis Dexa, extended progression-free survival by 8.2 months versus Velcade Dexa. And you can look at the red line versus the blue line. The red line is the Kyprolis Dexa, and this gave better progression-free survival. How about if patients had only one prior line of therapy? Well, as you can see, Kyprolis Dexa, when used as immediately second line, gave better results with a median progression-free survival of 22 months versus 10 months reusing Velcade Dexa, and this is very good. That means, that indicates that as soon as the patient relapses, the best scenario would be to give him a Kyprolis-containing regimen, because this increases the median progression-free survival up to 22 months, which is really great. How about if the patient had a prior bortezomib or a prior lenalidomide? Anyway, if the patient had bortezomib before or lenalidomide before, well, the median progression-free survival, as long as you are using Kyprolis, is always better. How about overall survival? Even overall survival, the use of Kyprolis in the relapsed refractory setting extended the overall survival by 7.6 months versus Velcade Dexa. Whether the patient had an early relapse or a late relapse, the median progression-free survival was always better with carfilzomib versus Velcade. Of course, it was even better with the late relapse, but even with early relapses, Kyprolis gave better median progression-free survival. And now this led to the ARROW study. Why? Because up till now, Kyprolis, carfilzomib, was used twice weekly. Days 1 and 2, 8 and 9, and so on and so on. But the ARROW study, this is the phase 3 study, including 478 patients, made use of Kyprolis or carfilzomib in a more practical way. They used weekly Kyprolis Dexa, and they compared it to twice weekly Kyprolis Dexa. And with the weekly dose, that would be 70 milligrams per meter squared given over a 30-minute infusion versus, and that was given day 1, 8, 15, and so on, versus the regular twice weekly dose of 1 and 2, 8 and 9, and so on and so on. And of course, Dexa was added in both arms, and these were compared in relapsed refractory myeloma patients that were refractory to most recent therapy, that had 2 to 3 prior lines of treatment, so they were really bad cases, and they were included even if they had a prior immunomodulator or a prior proteasome inhibitor. However, look at the level-treatment ejection fraction. They chose patients who had an ejection fraction of more than or equal to 40% because they were concerned regarding the cardiac function with the rather big dose. Of course, this proved not to be of value. The key exclusion criteria were an acute myocardial infarction less than 6 months ago and the presence of heart failure. Now, the primary endpoint was progression-free survival, and the secondary endpoints were overall response rates, overall survival, safety, because this was a high weekly dose. Exploratory endpoints were the time to progression and the duration of response, and other analyses included quality of life of patients. Now, key inclusion criteria, as we mentioned, however, these cases were also included that were refractory to most recent line of therapy, including other proteasome inhibitors, including bortezomib or ixazomib, which was third line. And look at the creatinine clearance. They only included cases with the creatinine clearance more than or equal to 30 milliliters per minute. Now look at the overall response rates. Overall response rates were better with the weekly group versus the twice weekly group. And now carfilzomib is comparing itself to itself again. But here, the once weekly dose was much, much better than the twice weekly dose regarding the overall response rate. And looking at CRs, more stringent CRs, and versus in the once weekly dose versus the twice weekly dose. And in conclusion, the overall response rate was significantly higher in the weekly group versus the twice weekly group. Regarding the subgrouping by age and renal function subgroups, well, in most cases, even in elderly patients, the overall response rates, as you can see in the red row, the overall response rate was better, always better in the once weekly versus the twice weekly. In patients that were less than 65, in patients that were 65 to 74, and even in cases that were more than 74 years old. And so this means that the use in these elderly patients proved of value to use the once weekly versus the twice weekly. How about the baseline creatinine clearance? Even cases that had a creatinine clearance of less than 50 fared better in regarding the overall response rate using the once weekly versus the twice weekly dose. How about patients that have had prior lines of therapy and that were bortezomib refractory? Well, even if patients had had 2 or 3 prior lines of therapy, the overall response rate was always better in red in patients receiving the once weekly versus the twice weekly dose. How about patients that were refractory to bortezomib status? I mean, they were refractory to another proteasome inhibitor. These are the tough ones. But still, as you can see, the once weekly dose gave good results even in patients that were refractory to bortezomib before. Now, we are now at the primary endpoint, which is progression-free survival. And as you can see in red, the once weekly dose fared much, much better than the twice weekly dose. And it is stated that the once weekly kyprolis dexa, the 70 milligram per meter square dose, significantly improved the progression-free survival by 3.6 months compared with the twice weekly kyprolis dexa dose of 27 milligram per meter square regimen, reducing the risk of disease progression or death by 31%. Time to progression was longer in the once weekly group than in the twice weekly group. How about the subgroup analysis? Well, whether the patient was below or above 65, whether the patient was male or female sex, no matter the race was, no matter the geographic region was, no matter the performance status was, no matter the baseline creatinine clearance was, progression-free survival was longer in the weekly group versus the twice weekly group across most subgroups. And this also included even the high-risk group and also the standard risk. It also included ISS stage, which was low or high. It also included patients that had prior 2 lines or 3 lines of treatment, whether the patient had had a transplant or not before, whether the patient had been refractory or not to previous bortezomib, whether the patient was previously refractory, had before lenalidomide or not, whether he was refractory before to lenalidomide or not. No matter the subgroup was, the progression-free survival was longer in the weekly 70 dose of kyprolis versus the twice weekly 27 milligram dose with the twice weekly dose across most subgroups. How about overall survival? Overall survival at 12 months in red was 76.6% in the weekly dose in red versus 71.9% in the twice-weekly group in blue. Well, they did not differ that much, but still the overall survival data were not yet mature at the time at this interim analysis. How about treatment exposure and dose intensity? Were the patients receiving a rather big dose once weekly? Were they forced to stop or to decrease the dose, or could they maintain the same dose on a regular basis for a long time? Well, as you can see, treatment exposure, median weeks, carfilzomib once weekly was better than the twice weekly regimen. And the relative dose intensity, whether the twice weekly or the once weekly, was the same. It was 96%. So the median treatment exposure was longer in the weekly group than in the twice weekly group, and the relative dose intensities were comparable between the two groups. How about safety data? They were worried about safety, but no worry. Overall, the safety profile was comparable between the once weekly and the twice weekly group. How about adverse events, special adverse events that were worrying but proved to be of no value, such as acute renal failure, cardiac failure, ischemic heart disease? Overall safety profile was comparable between treatment groups. And adverse events leading to carfilzomib discontinuation were comparable between the once weekly and the twice weekly groups. How about safety regarding subgroups? Well, there were more carfilzomib discontinuation in the twice weekly versus the once weekly in cases less than 65 and in cases more than 65 up to 74 years of age, and they were comparable in cases more than 75 years of age. Regarding cases with less than 50 milliliters per minute, there was more discontinuation in the once weekly dose, but other than that, they were favoring the once weekly versus the twice weekly dose. And so the once weekly dose was used safely even in the elderly group. How about quality of life? Well, patients had to go to hospital only once weekly instead of twice, and so patients receiving weekly Kyprolis in the 70 milligram per meter squared dose reported dosing more convenient, greater satisfaction, and improved quality of life among the questionnaires that were handed to them. And so, in conclusion, relapsed refractory multiple myeloma treatment horizon is broadening. Combinations including new proteasome inhibitors, immunomodulators, and monoclonal antibodies are giving good results. Carfilzomib once weekly combination is both safe and effective, even in heavily pretreated myeloma patients. Novel therapy will even make the future brighter. And I thank you.